Okay, good afternoon, good morning, good evening, depending on which part of the world you're joining us from. My name is Jonas Brunsvik. I am the CEO and Consul General of Swissnex in India, the Swiss Science and Technology Consulate, and I have the pleasure of welcoming you here today, physically and virtually, wherever in the world you may be, for this hybrid Science Curio, which we are grateful to do in collaboration with Euraccess, our friends at Euraccess and Nafik Neso, and of course our wonderful hosts and friends at CCamp. Some of you may know about Swissnex. You may have heard of us before, you may have worked with us before, you may have interacted with us before, but for those of you who don't, Swissnex is the science and technology network of the Swiss government. What you're looking at here is a global map of the scientific collaborations all around the world, and you can see it's a heat map, and there are some areas that are more connected than others, and coincidentally, these tend to be the areas in which we, Swissnex, are located. We are one of 6 brick-and-mortar Swissnexes around the world. We have been in Bangalore just 1 year less than CCamp. We've been here since 2010. I understand CCamp was established in 2009. And we really are a consulate for the future. Our mission is to connect Switzerland and India in education, research, and innovation, and we get to do this with a quite significant amount of creative freedom, meaning that we do not have a central authority that tells us what we need to do in order to be useful, but we can set the agenda. And what we're doing here today is not a one-off event. We're really just planting the seeds for something that we want to work on in time with this conversation on AMR. So I have been here for a year now, and in that year, tried to reflect on what does the collaboration between India and Switzerland look like. And I think in my mind, this image is a nice metaphor that stands for the collaboration between Switzerland and India. We have a nice set of growing trees connected at the roots. And it is clear to us that the potential for collaboration between Switzerland and India is to grow into a much more sophisticated and complex collaboration. And while at the moment, this is scattered a little bit across disciplines and field, there is no big coordinating effort behind trying to drive the collaboration. This is a role that we aim and aspire to fill now. And so we've identified a couple of thematic priority areas, health being one of them, and the other one in the field of sustainability. And in health, AMR is going to be the pilot phase in which we want to test a new mode for Switzerland and India to collaborate and find ways to work together so that in a few years, when we look back, we can say that the metaphor or the visual representation of the collaboration between Switzerland and India looks much more like this, a complex interdependent set of collaborative activities, and some of them grown much larger also through the coordination role that we aim to have. So in the conversation today, this is really just planting the seeds for us to do much more at a much grander scale, working not just with academic and research institutions, but bringing academia and industry from Switzerland together, bringing also policymakers and government agencies together to really try to figure out how can we make significant advances by bringing the two countries and others, since here we're collaborating with our Dutch friends together to address these issues. And with that, I'm going to hand it over to our wonderful hosts, the Varshini of CCamp, and wish you a wonderful afternoon.
Thank you. So, hello everybody. A very good afternoon, and thank you, Jonas, for setting the agenda so wonderfully. I won't take too much of your time because we have a great discussion on our hands, and I'll just take a minute to welcome everybody, all of you here to CCamp. I I think it is probably the first time for many of you that you are visiting CCAMP. So I'll just introduce you very quickly to who we are and what we do. We were set up by the Department of Biotechnology, Government of India in 2009, as Jonas said. And our mandate is to enable cutting-edge research and innovation in the life sciences. And what we do basically while decoding the mandate is we are a bridge between this rich academic community that we have in India and the industry and society to going forward. So we are a part of the Bangalore Life Sciences Cluster, which is one of the most reputed globally, not just in India, but globally reputed life sciences clusters in the world. And we are a very exciting deep science driven campus. We have, along with us, we have NCBS, which is our parent organization, National Center for Biological Sciences, which is in pure research. We have INSTEM, the Institute for Stem Cell Science and Regenerative Medicine. We have the Tata Institute for Genetics and Society, which has just joined us maybe 6 months back. And together we are a cluster who are addressing not only research, we are addressing innovation, we are addressing application, translation of science, so that we are completely addressing the entire research and innovation ecosystem. So what we do, CCAMP has more or less 3 verticals that we try to address, and we are providing access and training on high-end technology resources to researchers under our technology platforms vertical. We create new technologies and innovations through in-house translation, which is our research translation vertical, where we work extensively with academics across India in order to take their discoveries from the lab to market. And then we also offer entrepreneurial support to innovations for creating impact in society. That is actually a very important part of our mandate, as Dr. Taslim, if he had been here, would have told you. So we are very much focused on taking science from publications to society. And as Jonas said, so this event is on antimicrobial resistance, which, as you know, is a very important area for biotech research and innovation currently. And we are, if you are associated with us, you would have already known that we have quite an entire plethora of AMR activities, not just in 2022, for the last 4 or 5 years. We started with becoming a part of the Carbex Global Accelerator Network. Carbex is the world's largest not-for-profit public-private partnership that is trying to fund innovations in antimicrobial resistance. We have 2 startups already which have been funded by Carbex under this aegis, and we have Bugworks in drug discovery and module innovations in diagnostics. Bugworks notably is launching clinical trials for their first novel next-generation antibiotic. And this is a range of our AMR activities. Many of you who have joined today are possibly already connected with us on that topic. Among them, I would just like to draw your attention to India AMR Innovation Hub. That is a program that Jonas and Lena also are aware of, and we are interested in taking that forward. So this is a global think tank that is trying to shape policy towards antimicrobial resistance. So I think with that, I will just invite Lena and Dr. Kang to the stage, and then you can take the conversation forward. Lena, that's you?
Yeah, that's it. Can you stop the share? Yeah, we can stop the slides, and I hope we have our other speakers also on board. And we have a microphone for Dr. Kang.
Yes.
Okay. Okay. I start from here so I can use my notes a bit. Welcome. It is my absolute pleasure to host the first of many events that we have in the pipeline for AMR. It's a topic very close to my heart, so I'm very glad that I get the chance with the Swissnex to further this topic. In a world, so why did we choose AMR? In a world as connected today, it is evident that disease-causing agents like bacteria travel alongside their human hosts. Research and AMR surveillance over the last decades shows that the resistance of bacteria across the spectrum of antibiotics, including reserve antibiotics, has taken an uncomfortable speed, with a commendable impact on people's lives and nations' GDPs. The recent comprehensive report of the Global Research on Antimicrobial Resistances states very clearly that AMR is not a future threat. It is here, now. It's probably here since decades, but many might have chosen to ignore. It is because of cross-border health threats that we internationally need to work together on our global health security agendas in general and in particular on increasing our pandemic prevention preparedness and response. Hence, the question of how to build cross-border health resilience is not a question we can answer in isolation. It is a question we need to address together across country borders, but also across professions, where our title comes from, working on AMR, breaking the silos in AMR research. With this, we are here today to discuss and understand challenges and opportunities in cross-country learnings to make headway in the AMR crisis. And on this note, I would like to invite Professor Kang on stage. And you want to be closer to the microphone? Yes. Professor Kang is currently a professor of microbiology in the Department of Gastrointestinal Sciences at CMC Vellore, and she also has a medical degree. She's known for her work on rotavirus vaccines and for her tremendous efforts with respect to COVID policies and the implementing of the same during the very recent COVID-19 pandemic. She has been instrumental in setting up other disease surveillance programs in the country. And Professor Kang, we also invited you to be part of this conversation because, following the students' words, you have a unique combination of big picture vision and doing what it takes to achieve that vision. Alongside Dr. Kang, we also have Professor Andrea Indignani, who incidentally also has a medical degree and also is interested in gastrointestinal research. Jonas is has contributed to one of his studies on superbug emergence from the diplomatic network in Switzerland. And then Professor Indignani is currently an associate professor at the Institute for Infectious Diseases at the University of Bern in Switzerland. His area of expertise, among others, lies in characterizing multi-drug resistant gram-negative bacteria. He's also involved in the evaluation of new antimicrobials, implementation of novel disease techniques, epidemiological surveys, and clinical studies, therefore linking the antibiotic resistance with the outcome for human infection. Lastly, on the panel, I'm very glad to be joined by Dr. Nishad Matanga, who completed his PhD from the Indian Institute of Science, not far away from here, where he worked on signaling mechanisms in Mycobacterium tuberculosis. He now has his own research group at Isapuna, where his very interesting work focuses on deconvoluting the logic of AMR genetics at mechanistic and evolutionary levels. Nishad's research hopes to identify strategies for identifying evolution-proof drug combinations, an essential step for future treatment regimens. Now, without further ado, I would like to pose my first question to you, Professor Kang. Where, according to you, is the burden of AMR most strongly felt in India, and do you think it already has a felt impact on people's lives?
Well, I think when we think about antibiotics, their usage, and where you wind up seeing the greatest consequence of antibiotic resistant infections, that's really in hospitals, in tertiary care hospitals, in patients who have been within the healthcare system for a while. The advantage, even though the usage of antibiotics is much more outside the hospital, at least there you have options for progression. But in hospitals is where we have been seeing increasingly patients who die because they have no further access to treatments. This is not different from the rest of the world. What is different in India is the amount of resistance that we also have begun to see in the community. And that really is, as everybody knows, a lot of indiscriminate antibiotic use. So if you look at the carriage of resistance genes, even if people are not clinically affected, within the community, the burden of resistant organisms is very much there in healthy people in our environment. So not a burden currently, but promise of burden to come.
So you would see that, if I understand right, a bit as a ticking time bomb, that sooner or later.
Pretty much,
will have
you've
a
seen
impact.
excellent examples of what happens when you ignore such issues with the extensively drug-resistant typhoid that caused an outbreak in Pakistan about 5 years ago, where essentially you had no oral drugs left to treat children with, and you wound up having to admit children and treat them with IV antibiotics. And where we are in Bangladesh today and in India is the same Salmonella typhi. While we don't have exactly the XDR strain in India, we're beginning to see azithromycin resistance, and that means we are looking at an organism where drugs are no longer going to be useful outside of hospitals.
I want to just give the same question to Dr. Indaniani to hear his view. Where do you think is the burden of AMR most strongest felt in Switzerland? And do you think it has already impacted people's lives?
Well, first of all, thank you for the previous introduction. Well, the epidemiological situation in Switzerland is very different compared to India, because if we consider the different settings that we can summarize in human and non-human settings, we see a very different situation, and the reasons are multiple. But for example, in the human medicine, the prevalence of multi-drug resistant bacteria is much lower than India, but I have to say that is also lower than the average we observe in Europe, probably because the overall healthcare system in Switzerland is working very well, and we can prevent the diffusion of multi-drug resistant bacteria. Now, in my opinion, the problem of Switzerland is the non-human settings, and in particular, we have several settings that are concerning. We recently observed, for example, that in the animal setting, and in particular in the veterinary hospitals, we are observing something that we observed 20 years ago in the human hospitals. So the spread of superbacteria among the animals or in the environment of the hospital. And that's because at the moment, the veterinary hospitals do not apply the same preventive measure that we apply constantly in the human hospitals. So this is one of the major problems. The second problem we observe is the diffusion of these bacteria in the food chain. We have a system that constantly checks the presence of superbugs in chicken meat or other food chain products, and we have a quite high prevalence of superbacteria that usually are not, how do you say, autochthonous, but usually they come from other countries. They enter in the food chain system, and then they spread among the people working in those settings or among the healthy people. The last problem we have, and I like to study especially this setting, is the international travelers. We have Swiss people like to travel a lot in everywhere, in many continents, very frequently. And the problem is that when they visit a country where there is an high prevalence of superbugs, they return colonized at intestinal level with this kind of bugs, mainly Escherichia coli, producing ESBLs, but not only. And so the problem is that very frequently these people import in our country that is defined as a low prevalence country, bacteria that are present in other country, and then there is the risk of transmission to the householders, to the environment, or even to patients then admitted to the hospital. So in general, this is the situation. We have several critical points and other where we are quite relaxed, like the hospital setting, because we don't see an high prevalence.
How would you judge the situation in the animal sector or the veterinary sector in India?
So if we look at sampling of animals to see what antimicrobial resistance genes are present in them, that is actually quite restricted in India, given the size of the poultry industry that we have, as well as livestock. However, if we look at the inputs into the animal industry in India, that is frightening, because there is such a large usage of completely unrestricted usage of antibiotics. The amount of antibiotics that goes into feed in India is, I think, unparalleled anywhere in the world. And the antibiotics that are being used are the antibiotics that we use for human diseases. And whether that actually fuels the resistance that we see in communities in India, or whether it is something that is much more restricted, because by the time you cook meat, you no longer have the bacteria present, is not something that we know clearly yet.
It brings me a bit to Dr. Nishad's research. So I wanted to know from you, Nishad, what inspired you to pick your research topic, and do you take motivation and inspiration from public health challenges? And also relating to Professor Kang's comment, as far as I understand, you look at the evolution of resistance mechanism in relation to the concentration of the exposure to the concentration of antibiotics. And I guess something like that is that you might have like low dose antibiotics, which might trigger resistance. I'll let you answer this question instead of speculating any further.
All right, thanks, Lina. So just sorry, before I answer your question, I don't think I can hear you quite as well as I can hear Dr. Kang. So maybe a little bit of an adjustment of the microphone would help. Okay, yeah. So I think that of course there is motivation from public health. I think that AMR has been around for longer than antibiotics have been used as clinical tools. We know that AMR genes, for example, are extremely ancient. You can detect them in bacteria from Egyptian mummies and things like that. So I think that bacteria have innovations that allow them to survive antibiotics, simply because antibiotics are also finally natural products. But once humans have started to use antibiotics as therapeutics, what we've essentially done is that we've changed the kind of concentrations of these chemicals that bacteria are going to face. So what this means is that if we follow a kind of Darwinian model of why antimicrobial resistance evolves, we are essentially just hiking up the selection pressure that these bacteria face for antimicrobial resistance. And so it follows really that we should see such high prevalence of AMR because we're using tons and tons and tons of antibiotics, as both the other panelists have pointed out. Now, the issue of concentrations of antibiotics is really, really interesting. And in many ways, I think it's almost a cross-disciplinary sort of study, because at a fundamental level, it's a biochemical problem, which means how much antibiotic do you need really to stop the growth of a pathogen or a bacterium. So at that level, we're talking about a biochemical problem. We're talking about a microbiological problem because different bacteria, based on their life histories, will respond to different kinds of antibiotics. So, there's really no single antibiotic that works against the entire spectrum of pathogens that we're likely to be exposed to. And of course, no pathogens exist in silos, right? We don't have, our bodies are not pure cultures of bacteria. So you're essentially trying to target a pathogen of a particular kind, but you're pretty much exposing all these other bacteria that are living in your body, which could be either pathogens or not, to this antibiotic. And each of these bacteria are going to essentially interact with the antibiotic in different ways. And so, we really don't understand how, concentrations of antibiotics that are therapeutic for one set of bacteria will affect a completely independent, class of bacteria. And of course, the third and perhaps the most direct, reason for looking at these concentrations and how they affect the evolution of AMR comes from applications like use in animal husbandry. So essentially what you're looking at is, antibiotics like Professor Kang said, which are essentially used as human therapeutics, being used in animals, where they may either directly select for resistance in the bodies of these animals, but then you also have antibiotics, therefore, entering the larger ecological milieu in which animals and humans coexist, right? So into soil, into water, into food chains, as Dr. Andrea was also talking about. And so in all of these different ecological sites, the concentrations of antibiotics, the durations of exposure, whether these exposures are continuous, discontinuous, whether these exposures are happening, as a single antibiotic, multiple antibiotics. We know that heavy metals and antibiotics seem to have synergistic effects on how quickly resistance evolves. So it becomes an incredibly complex ecological problem, in addition to a biochemical and a microbiological problem, and of course, which has really huge repercussions for public health. And so this, I think, for me, as somebody trained as a microbiologist, was the most fascinating aspect of trying to understand and eventually curtail the spread and evolution of AMR.
Thank you so much. Before I ask a follow-up question, I also want to say that I would like this to be a conversation, so I don't need to always be asking question and answers. So if anyone would like to pick up on what one of the previous persons has said, please feel free to do so.
Do that.
Great.
So actually, I wanted to comment on what Nishad said, and speaking to why you are having these series of meetings, is perhaps we've approached AMR wrong in some ways by making it a medical problem. And we need to be thinking about making it more of a societal problem. Because this is about the fact that antibiotic residues, so pollution, factories, what's happening with them, all of this really needs to be integrated. And the example that Andrea gave of Switzerland is something that is actually echoed around Europe. The argument is made for antibiotic usage the way it is done in India or in the animal husbandry field is that we need it because otherwise children will die or people will die. So indiscriminate antibiotic use at cheap prices without regulation is a way of ensuring access, right? And this is a story that has been going on now for decades. Now, 25 years ago, when I was in the UK, their rates of MRSA were climbing to 70% of all the isolates in hospital. 10 years later, it was less than 5%. And the way they were doing it, and I assume this is the way that it's done in every place that has managed to control antibiotics, is by compliance and guidance. And in India, for some reason, we seem to be unable to implement that guidance except at very, very small scale. So when we think about what happens in society, what happens to people, what happens in hospital, all of that needs to come together for us to be able to think about addressing this problem, because scientists cannot do it alone. So when you talk about silos, make sure you have social scientists in there as much as you have people that are invested in the deep science that's here on this campus.
That actually brings me to one question I had on the list, because just this morning I read a piece on the influence of urban, or the role of urban design on AMR. And it started with like cities once fought disease by improving airflow and access to sunlight. Those early public health interventions are increasingly, and then it goes on to describe the impact of urban design faults in Mumbai, fueling the prevalence of MDR TB. And it was more of a closing question, but it maybe fits now since you raised it. I was wondering, what is your take on this? Do you think it's worthwhile to expand the conversation on AMR beyond the medical and research and public health professions to involve urban planners, architects, storytellers even? Like, can we write on the COVID-19 awareness strategies that we built to build AMR awareness strategies? And I don't know how compliance and guidance worked in Switzerland. Would you be able to comment on that? Like, how did Switzerland like go where it is now?
I'm sorry, Lena. I honestly didn't get completely and well your question. So if my understanding is that we are discussing the policy, what we can do, the broad approach we can implement to prevent antimicrobial resistance. I first emphasize that recently we concluded in Switzerland an enormous project called NRP 72, that is National Research Project 72, where we try to face the problem in different ways, mainly in 3 ways: design new antibiotic and new diagnostics, implement new policies in and out hospital to prevent transmission, and 3, try to identify the spots, the setting where antimicrobial resistance is spreading more and how we can try to prevent them. I'm sorry if I'm not answering to your question, because the mic many problems. So if I can comment about 2 or 3 things my colleagues discussed before. The first is the spread of antibiotics in the environment and the impact of them in the evolution and spread of antimicrobial resistance. Yes, it's true, but as anticipated, we are speaking now about multi-drug resistant bacteria. And this kind of bacteria is also resistant to chemical compound, heavy metals, disinfectants. So be careful, because we can select multi-drug resistant bacteria even if in the environment we don't have antibiotics, because in the plasmid, in the chromosome of bacteria, we have many systems to protect them, and we select carbapenem resistant bacteria just because we have chemical compound in contact with them. So now the approach should change. We are not in the 90s where the idea was, I use this antibiotic, I create this resistance. No, it's not anymore this the point, because I can use another antibiotic and I select a bug that is resistant to a completely different antibiotic. Example, in India, there were reports in the rivers with a high concentration of fluoroquinolones, that is a family of antibiotics. Those fluoroquinolones selected for ESBL producers, but it's just an example. The second thing I want to say is that the type of bacteria we want to face and reduce is very important. Dr. Kang cited MRSA, the example of UK, that is the best example to show that if we do something very well, we can reduce the prevalence of bacteria. But in that case, was an MRSA gram-positive spread in a very different way than gram-negatives. So we have always to deal also with the species, because gram-negative use mobile genetic element, plasmids, etc. MRSA and the gram-positive spread clonally, the same bug transmitted with the hands, etc. So you see how complex and difficult is this problem of antimicrobial resistance. So here I put on the table several comments. Now I don't know if my colleagues wants to add something.
Nishad, I don't know if you want to go next, but when it comes to gram negatives, we all recognize that they are a bigger challenge than gram positives in many ways. But for gram negatives, even though we say lots of doomsday scenarios, it is possible to think about what happens when you remove antibiotic pressure. Because when you take antibiotics out of circulation, then Nishad should comment on this. You actually wind up after generations that you will have a bug that is sensitive again. It doesn't happen with every organism, it doesn't happen with every antibiotic, but it is something that is feasible. The problem is getting people to work together across fields. That doesn't happen very easily.
Yeah, I absolutely agree, actually, with both with Professor Kang and with Dr. Andrea. I think thinking about, so, in many ways, it's another kind of silo. It's sort of an intellectual silo because, people who are looking at drug-resistant TB, for example, versus, drug-resistant Klebsiella, which is something that we're really struggling with in our hospitals at the moment. In principle, it's all antimicrobial resistance, right? And you can sort of put it into one large bucket. But really, these are two different beasts. And obviously, I think we would benefit from learning, from different kinds of bugs. But, each system has its own sort of eccentricity. And this is really determined by, what kind of bug it is, what kind of a bacterium it is. There have been studies, I know, where people have tried to withdraw an antibiotic, both, studies that were mimicked in the lab, where we were essentially just, looking at very controlled environments where you can, pull out, where you allow resistance to evolve, and then you withdraw the antibiotic and look at what happens. And also actually in a sort of controlled clinical setting where over a period of time you switch what kind of antibiotic gets used for the treatment of a particular kind of infection, let's say UTI or something like that. The success has been fairly patchy is what I understand from my reading. And part of the reason for this is that depending on the burden of resistance that you start with, you can actually end up with very different kinds of outcomes of these kind of withdrawal experiments. So there are a number of reasons why we would expect that resistant bugs, if they don't see the antibiotic for extended periods of time, should revert back to becoming sensitive to the antibiotic. But there are an equal number of reasons why they shouldn't. And many of these are related to, things that evolutionary biologists have been talking about for the longest time, which is that resistance can be costly for the bacterium. And, carrying these plasmids with these extra genes, which, they don't need all the time, can actually impose costs on the bacterium and can induce, if you withdraw the antibiotic, loss of plasmids and therefore reversion to a sensitive phenotype over extended periods of time. But honestly speaking, from the studies that I've seen, the results are patchy. So it's anybody's guess at this point of time. I think, or let me put it this way, I think it's very system specific. So depending on the bug that you're working with and the antibiotic that you're working with, you're likely to have very different outcomes of withdrawal of the antibiotic.
Nishat, how do you bring your learnings into practice or the next generation of drug research? And do you sometimes talk to clinicians as well? Do you talk about your learnings, or do you ask them about their experience?
Yeah, I think that's a fantastic question, and I think that one of the things that needs to happen more and more is dialogue between clinicians and people like me who sort of potter around in the lab. I think that so I do have collaborators who are clinicians. Let me point out a couple of challenges before we talk about the the way ahead. So I think one of the challenges is that very often clinicians and researchers like me don't speak the same language, in the sense that when I say resistance, I don't necessarily mean the same thing that a clinician means. When I talk about other allied phenomena, so now we know that resistance is sort of a very large term which encompasses a number of phenotypes. For example, you can have phenomena like heteroresistance, where essentially you have populations of bacteria that seem to be drug sensitive, but you have subpopulations within these larger populations of bacteria that can be resistant. And so essentially something like this at a clinical level would be classified as a sensitive bug, right? And you would think that therapy should work, that treatment should work, but then treatment fails because essentially there was a subpopulation in here that was hidden and it was resistant. So essentially a lot of these terminologies, a lot of the jargon that we use to talk about AMR, has slightly different connotations for clinicians and for basic scientists like me. So while we do engage with clinicians quite a bit, and we should, because really they're the ones who are seeing a real world manifestation of this problem, I think that finding common ground, both in terms of concepts, in terms of terminologies, in terms of ideas, ways ahead and things like that, is really something that needs a lot of effort to find that common ground.
I totally agree with you. The educational point is essential, especially among the experts, the clinician and macrobiologists. The medical school, in my experience in Italy, Switzerland, and United States, does not prepare at all very well the clinician to use adequately the antibiotics. They don't know very well the antibiotics. Another problem is the other way. So the macrobiologist is an expert listing the antibiotics, but very frequently does not know if it can be used or not, because they just put S, sensitive, or R, resistant, but they don't know the dosage. They don't know if it can be used in a pregnant woman or in a child, etc. So this is another aspect that also in Switzerland we are pushing a lot in the so-called FAMH specialist course to improve the quality, the knowledge of these people, because if you use well the antibiotics, then of course you impact less in the antimicrobial resistance.
Couldn't agree more, because whether it is a patient with a chronic renal condition or somebody who has liver damage, you will need to adjust the treatments that you have.
Mm-hmm.
And what we see frequently now is also, if you don't understand, you think you're doing better by giving more. And that is absolutely not the case for the dosage or the classes of antibiotics that are being used. So even educating specialists who are trying to do the best they can for their patients, but actually winding up overusing antibiotics. is something that is really important for physician education. Recognizing when you can de-escalate, recognizing when you can switch from IV to oral. All of these are things where medical education does not place enough emphasis at the undergraduate or the postgraduate level.
There is also a very important role of the pharmacy, I forgot. The hospital pharmacy, the pharmacists in hospital, but even outside, they are key people to manage this overall situation. For example, in some countries, even if you need a prescription for antibiotics, you can enter in a pharmacy, ask amoxicillin clavulanate, and they give it to you. I frequently travel, for example, in Italy, where you need a prescription, and if I ask the antibiotic, they give it to me, even if I don't show my medical card. And this is common also in other countries.
You want to hear this one? During the COVID pandemic, what has happened is that a lot of pharmacies have set up IV infusion rooms next to the pharmacy. You can get tazopicillin infusions in the pharmacy now. It's
Perfect.
easy.
For people like me, it's perfect, because I will have a lot of new strains to study.
Wonderful. I'm actually very glad to see that there are so many commonalities between the two countries, because I think often it is seen a bit that the superbugs come from India and that in the Western world, like, things are pretty much in control. And it's really a nice learning for me to see that challenges are common in the two countries, which I think also means that there's a lot that we can learn from each other by sharing our experiences, see what works or doesn't work. I mean, as a last question, maybe to close the loop a bit, like, again, tackling this sort of quote unquote global south and global north, compliance in production. Like, I mean, I believe in Switzerland also most of the antibiotics would be produced in India, while the compliance of production is probably not always 100%, which means the production of the antibiotics here for the Western market actually fuels resistance development in this country. So how do we look at the responsibilities there, or how can we work together to try and make this better?
Well, this is a political question, not a scientific question. Well, it is well known that most of the powders for antibiotics, but also other drugs, are now produced in India, China, etc. This is a problem for those countries, as I anticipated before, because the powder, the residual, can go in the environment and contribute to the selection. This is one problem. Another problem is political, but I'm not here to speak about politics. I just make a short statement. It is clear that then when you have a war, not in the case of India, but if everything is produced in one country or two countries, then when there is a problem, you have a shortage or you don't have anything more. And in the case of antibiotics, is one day India decide to close the gate and say, no, we don't give you any more powder. Europe and North America will remain without antibiotics. So from a political point of view, I would say that this is a problem that then translates in the scientific problem.
I think the whole issue of supply chains is something that really came up during COVID.
Yes.
But I think there is another point that I would like to make, which is regulation and quality, because frequently there are different standards that are implemented for different markets. And we have to understand that if you have a substandard product that goes into a market, Africa, India, wherever it is, you're actually setting yourself up for more harm than good. Nisha had raised his hand.
Okay. Yeah. So I completely agree with both speakers. Um, I wanted to bring up another issue. And the issue of policy, I think, is of course something that needs to be discussed by people who make policy. Having said that, I think that looking for universal solutions at the policy level is not really going to work. In India, part of the reasons why, so since 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 there's a large number of people who live in India here, when you go into the doctor's clinic with a common cold, you very often come away with a prescription for antibiotics, right? Even though it's most likely a viral infection. And in India, the prophylactic use of antibiotics, particularly for things like viral colds, for the common cold, and all of these things, is it may seem alarming and all of that, and promoting resistance and all of that, but the pathogen load in countries like India is also much higher than it would be in places like Switzerland, right? And so the need for prophylactic use of antibiotics is perhaps justified. So what that means is that antibiotic stewardship in different parts of the world, probably means different things, and so policy, probably needs to be designed appropriately. And rather than sort of dismissing our clinicians and pharmacists who are sort of trying to keep, I suspect they have good intentions. I would be wary of sort of writing them off as perpetuators of the AMR pandemic. I think that taking them into the fold and really trying to understand why certain practices have become, with regards to antimicrobial use, have become so common in countries like India is probably something we need to do. I mean, we need to know why doctors are prescribing antibiotics the way they are. We need to sort of understand what their motivations are. And this again goes back to what Professor Kang said, that it's not just a medical problem. There are people involved, and so we need to start thinking about how people respond to all of these challenges.
I think I've actually taken up too much time with the question and wanted to open the floor to the audience before we close the session. Do we have questions right here in the audience? Okay, so Dr. Shahid Jamil in the audience, could you unmute yourself and ask your question? Shahid Jamil? Okay, if not, then I know we have 6 questions in the Q&A box already. Could you bring them up?
Yes.
Okay. So Nishat, there is maybe one question for you. Do you think there is an opportunity to use genetically modified bacteriophages that naturally target AMR bacteria instead of antibiotics?
Yeah, I was wondering when that would come up actually. Because, so phage therapy is something that people are looking at all around the world, and there's definitely promise there, but there's a lot of challenges as well, particularly because we don't know what will happen to these phages once you've introduced them into a patient. There's some really nice things about phages in terms of their host specificity, for example. The way that it'll sort of auto amplify inside a host. So you could start off potentially with low doses of the phage, and it will sort of, because it'll feast on the bacteria it's going to, population is going to build, but we really don't know what happens to those phages after that. So there's a very high chance of them crossing over to species that they weren't able to infect before, which means that these phages could now start infecting your common cells, your all the other bacteria that live in your body. And I think we're a long way from really being able to use phage therapy as a standard alternative to antibiotics. Yeah, so there's promise for sure, but I don't think we're quite there yet.
May I add a comment about bacteriophages? So
Yes, please.
I agree partially. Bacteriophages treatment is very old, more than 100 years. I think there is a kind of area where we can try to apply bacteriophages, for example, as it is in Western country, in European and Western country, Eastern country, sorry, topical use for an infection of the skin or the eye or the hair. This is okay. We have a lot of experience. In my laboratory, we tried to use the bacteriophages to decolonize the intestinal tract. Now, to make short the story, there are two problems. The first is that if you use a cocktail of bacteriophages, maybe you can get rid of the bug you want to eliminate, but then you have an effect on the overall flora at the intestinal level. So you disrupt the microbiota. But the second problem is more important, that even in this case, like for antibiotics, bugs are very smart and they become resistant. So my opinion is that we have to try to manipulate genetically bacteriophages, is okay, target specific, but we have to mix them if we use them for the treatment together with the antibiotics at the moment, to try to lower down the possibility that the bug become resistant. So mix bacteriophages and antibiotics. For example, in my laboratory, we had a model of respiratory infection with MRSA, and the combination was working quite well. But I don't have doubt that in future, bacteriophages will be considered as it was recently to treat, for example, pan-drug resistant bacteria like Acinetobacter. So it's a kind of salvage really last option to try to save a person when the infection cannot be treated with standard antibiotics.
If you can have a look.
Okay, I think there was one question up which was a bit about the diagnostic setups. Like for clinical microbiology diagnostic setups in towns and smaller cities in India is a big hurdle. What is your take on that, Professor Khan?
Well, Dr. Vattal is absolutely right. Most often we don't test to figure out which antibiotics are appropriate. We tend to give antibiotics empirically, and that may be fine in some situations with patients who come in urgently. But if you had antibiotic resistance profiles for bugs in that area, then you could target therapy much better. Dr. Vattal is also right about the One Health approach. And to Dr. Jayaraman on top, if you treat water enough to get rid of the bacteria, you've also gotten rid of the AMR resistance gene. So yeah, there are opportunities there. I think we've reached Anshu Kardwaj.
Yes, and Anshu, I think poses a very big question, which is the number one priority if we were to address AMR, or what is the most impactful policy change required?
So I would say there are actually two priorities. And one, despite what Nishad said, is regulation. making sure that restricted antibiotics are not freely available. The common antibiotics, sure. If you want to say you want to promote access, have them available, but restricted antibiotics really should be restricted. There's a good reason for that. The second is really to invest in many aspects of R&D, which I think needs to be a priority for policymakers. Because without that, you don't know the direction you're heading in for the future.
Nishat or Andrea, would either of you also want to bring up
Well,
your priorities?
For sure, I agree that for India, the priority is the policy. Try to stop the indiscriminate use of antibiotics in many settings. This is not a problem that we have in Switzerland. For Switzerland, the priority, well, I like to say always that there are no priorities, but we have many things to do, because is a multifaceted problem, antimicrobial resistance, at least for European countries where we have already set up a lot of countermeasures. So research and development, for sure, this can focus, of course, in the rapid diagnostics and in new antibiotics. But for example, if I'm in another country, medium low income country, rapid diagnostics is not a priority, because take into account that a test with a rapid diagnostic is very expensive. We are speaking about tests that are at least $50, but sometimes they can be 200, 250. So depend where you are, depend on your setting, the strategy that you use to try to limit antimicrobial resistance. So probably for us, as I said at the beginning, the priority is the veterinary hospitals, and also try to understand, I didn't mention this problem that is another hot topic, the waters in general, the spread of superbugs into the water system that we noted in Switzerland is of course an indicator of pollution that is coming from humans, animals, etc. Is an indicator, but we don't know yet if swimming in the Zurich lake that is full of these superbacteria and fish colonized with superbacteria, I have the risk to get it. This is an open question. So the part of the environment is a bit concerning for Switzerland.
So if I may also respond, Lina. Okay, so obviously I think it's hard to pinpoint any one intervention. Obviously, there will be no single policy that will cure all of our woes with AMR. It's an extremely complex problem. But I think something that perhaps wasn't mentioned is funding. I think that we need to come up with innovative ways to fund people who are going to look at the problem of AMR using a sort of multi-pronged approach. From what I understand, I believe that any new antibiotic that gets released into clinical use has a half-life of about, maybe not a half-life, has a lifetime of about maybe 10 years. So what this means is that for a pharmaceutical company, which is really the only setup that at the moment is able to, accelerate the rate at which we're discovering new antibiotics or modifying old antibiotics, there simply isn't enough, financial incentive to put in the kind of money that goes into finding new antibiotics, because by the time they're able to get this money back, it's over. You probably can't use the antibiotic anymore as effectively. And so obviously there has to be some kind of incentivization for antimicrobial research, for antimicrobial discovery kind of work. And I don't think that we have these kinds of systems in at least in India.
Well, it's common in every country, not only in India, don't worry. Development of antibiotics is not in the target of medium big pharma companies, because they prefer to give me every day atorvastatin or statins to control my cholesterol than an antibiotic for 7 days. They spend 2 billion in 10 years to obtain a product that is sold in the market, in hospital, for 7-10 days every 3 years on average. So, of course, they need to make profit. For this reason, we have associations like Carbex, etc., but still is not enough, because we need an enormous amount of money to find new antibiotics. And this is an open discussion that we have already since 2010, when there was a paper 10420 published in Clinical Infection Disease. We need 10 new antibiotics for 2020. And how many we got? 2 that are the same class of antibiotics that we had already. So it is very difficult to find a solution unless we have a person like, I don't know, Bill Gates is coming and says, I give you all of my money to find 5 antibiotics. Then you find the 5 antibiotics, 3 years later, all bugs are resistant. Oh, so, you know, it's very difficult to solve this problem.
Excuse me, I have a question.
Yeah, of course, please. It's open to the audience from here.
I have a question to the speakers as well as to others also. Yeah, I'm Professor Roy from Institute of Health Management Research, Bangalore. Being a pharmacist as well as being into the pharma industry from past 15 years, what I've seen that the pharmacovigilance and as well as ADR in India it is still in nascent stage. Like if I talk about TB reporting as well as the drug resistance for TB as well, there are multiple drug resistance also happens in TB. So if we can compare that along with what we are discussing here, AMR also, and even MDR, so it is quite similar in that case. So if you can actually think of, yes, like we can actually connect all the hospitals as well as all the clinicians and laboratories, like whatever the resistance we are getting, okay, you can report it. And also it could be like kind of like all the IT companies like McKinsey as well as Infosys, they're also working on these kind of things, like they're reporting and they're coding it right now with the all tools and all. So how we should approach particularly for the big, because still right now 1% or 2% of data is right now in the repository. I think most of you will be agreeing on that. So just need some comment on this. Yes, thank you.
Happy to comment. So, you know, most of research on AMR so far has been restricted to the research domain. It has not been about setting up a database that tracks things over time. There are centers of excellence in India that have been doing work on AMR, but that is sampling. It is not a collective of all the information that is generated in the country. That's actually not just antimicrobial resistance, it's for every infectious disease or every disease that we study. There is no tracking system. So having data systems that measure what we are seeing is important. It is something that has been recommended for a long time to the country. Does not exist today.
Well,
would you like to speak about?
Yes, I comment. In Switzerland, since 2006 or 2007, we have the Unresis platform. So basically, is the database where we collect all of the information about susceptibility test for bacteria from the main laboratories located in Switzerland, university hospitals, private laboratories. You can see it is an open platform. So basically, we know every year the prevalence of the resistance for this antibiotic, for that antibiotic, etc. And I think is extremely important to start a program, an overall program to face antimicrobial resistance in India. If you don't know what you have around, you cannot plan what to do. So this is, in my opinion, the first step. Now in Switzerland, since several years, we have also in parallel another center that is collecting the multi-drug resistant bacteria and characterize them. We do this because we need to have national information about carbapenemases, CSBLs, etc. And is in program a kind of platform that merge both, where we will add also metadata. So we have the phenotype, we have the genotype, and in future we will put also, let's say, clinical information, the person, the age, where he's living, etc. Because also this part is extremely important to understand the overall business of antimicrobial resistance. So about this, I have to say that Switzerland and other 2 or 3 countries in Europe, like Denmark, for example, they are in good shape, really, and we have experience about this. We lost connection. I see only Nishad. We are just 2.
Perhaps we've lost the. Okay, we'll give them a minute. Maybe they'll figure this out.
Yeah, let's wait. Never happened to me that, maybe they are coming. Yes, we see you partially.
Recording in progress.
Sorry about the.
Yeah, sorry about the disruption. We just had an internet drop. Just stay tuned for a minute or so. Yes. Okay, so I'll be very brief about the Connect with Europe section. So we'll be talking about how you can connect, study, research, and innovate in Europe and the various scholarship opportunities which you have accessible to you. These are the ways SwissNext in India is currently collaborating with Switzerland in the field of AMR. These are the institutes and the list of startups, as you can see. I'll be briefly talking about the Think Swiss Research Scholarships for the Asia Pacific region. So basically, the scholarship is open for Indian bachelor's and master's students. The duration is 3 months, and the scholarship lasts for 2 to 3 months, and it gives you a living allowance of CHF 5,400 if you're going for 3 months. What's unique is that a lot of scholarship opportunities are quite long in duration, and this is one of the shorter scholarship opportunities which you have accessible to Indian students, Singaporean and Australian students. Next, we have the Swiss government excellence scholarships. So you have 3 grants for PhD and postdoc researchers. The duration is 12 months long, and for PhDs, it is 3 years. Again, this is a scholarship program which is being coordinated by our embassy and the Federal Commission for Scholarships for Foreign Students, the FCS. They are aimed at young researchers from abroad who have completed a master's degree or PhD. We also have the funded PhD and postdoc positions. Duration of the PhD position, as you can see, is 3 to 4 years, and for postdocs, it's 1 to 2 years. And these are the sources which you can access to avail or look for these funded PhD and postdoc positions. You have the academic positions, non-PhD and postdoc, and there is a high demand for these 3 disciplines, which we have mentioned on the slides, and these are the 2 open. You can check out these websites for the open positions. We do not have Dr. Samrat, who is the Euraxis representative, but I'll just briefly give you a snapshot about Euraxis. Euraxis too has open positions for PhDs, and they open calls across different disciplines, and currently they have 8 PhD positions for electrical mechatronic engineers. They have 12 PhD positions in eye tracking research called under the ICE for ICU initiative. They have 12 PhD positions across various fields within the READY program. Yes, and they also have 12 doctoral candidate positions for MSCA doctoral, for the MSCA doctoral, under the MSCA doctoral network. So these are the positions which are open on the Euraxis website, and you can access them. Yes, just a quick snapshot about what Euraxis is doing and the successes they have had when it comes to funding in science, technology, innovation, including social sciences and humanities. These are the social channels for Euraxis, and you can get in touch with Dr. Samrat Kumar if you have any further questions regarding Euraxis. Now I'll hand over to Nufik Neso for their short presentation, and over to Mr. Rakesh Varte, who has joined us virtually. Just 1 minute. Rakesh, you can continue, please?
Yeah,
Yeah, perfect. We can hear you.
myself. Hi, myself Rakesh Varde. I am looking for Diffusion India Consulate General Office from Bangalore. We have also studied in Holland. We have a specific programs for PhD also. Can you go to the next slide? You can find you can find the study program on this portal studyfinder.nl, and if you have any queries, can you go to the next slide? Contact me. That is our generic email ID and address in Bangalore. Yeah, that's all from my side.
Okay, great. Thank you, and Nishat and Dr. Nishat and Dr. Andrea. So sorry, we lost internet connection in between, so we lost you there. Thank you very much for being part of this discussion. It was really, really insightful. And before I let you go, my last question to you as well: where do you see is the largest potential, or how do you think should Switzerland and India work together on this topic to make some headway?
Very difficult question. I do not want to compromise me and my future. No. Well, what we, as anticipated, for example, we can help and support to design this kind of platform to make a national survey to explore the impact of antimicrobial resistance. But for example, from my side, but not only my side, there are 3-4 groups in Switzerland that has a lot of experience with the molecular approaches to characterize the bugs, the super bugs. We also have a kind of oasis in Switzerland because most of the pharma companies are located here. And so there are many opportunities to establish kind of relation with companies, even small, to develop new diagnostics and new antimicrobials. So it should be very easy if the idea is good to find a company and establish a partnership between Switzerland and India. And of course, Switzerland has an enormous experience in the policy, in the use of antibiotics, starting from the JP, the family physician, and arriving to the hospital setting that can be suggested and try to be implemented. I would say that there are many opportunities. I will not focus only one. We can rediscuss these things a lot, but is enormous. The possibilities are enormous with Switzerland and India. We can learn a lot from India, especially about the new emerging multi-drug resistant bacteria, for example.
Yeah, I think three main areas, I think, where bilateral cooperation will really help. I think the first is data. Sharing data across countries will really be a useful step, not just for India and Switzerland, but pretty much any such collaboration at the international level. I think data needs to be shared across countries, whether it's surveillance data, whether it's data on prevalences. We've got to kind of be faithful to these data, and we've got to share them. The second area that I think would really benefit, like Andrea pointed out, was engagement with pharma. Switzerland has some of the sort of top pharma companies internationally at the moment housed in Switzerland. And so what that means is that increasing opportunities to engage with pharma, whether it's through engagement between let's say startups and established pharmaceutical industry, or academia and pharma, or having more postdoctoral opportunities in pharma
Yes.
might definitely be beneficial. And I think the third is in terms of education. So I think that India has a need to upskill its education, both in terms of AMR and in terms of scientific education in general. And I think we have a very strong student base that will benefit from the resources that Switzerland has to offer. The flip side of the equation also is that India is a very interesting ecosystem for a subject like AMR. And I think this is something that must have emerged through our entire conversation, right? There were so many dimensions to AMR. And I think that Swiss students who benefit from spending time in India and sort of understanding the complexity of problems like AMR in a country like India, which is sort of massive, with tremendous diversity, both in terms of the challenges that we face in different parts of the country. So I think the three areas would be, the third of the areas would definitely be in education.
I totally agree. Exchange of young people. We have always many requests from India for PhD students and postdocs, but we cannot satisfy the request. It was before mentioned a program, for example, this Swiss scholarship. Every year I get 3-4 requests from India, but we were unable to get this scholarship because there are so many requests worldwide, not only India, because they are all of the country together. So try to expand this kind of programs focusing on India, I think is another priority.
Wonderful. So on that note, thank you everybody for staying on with us. Thank you, Nishad and Andrea. It was truly wonderful. And I'm very, very glad, as you said before, to see so many commonalities and so many areas where we can learn from each other. We hope to make in-person meetings possible in the next year. As I said earlier, we have a lot of things in the pipeline. Stay tuned. And yeah, once again, thank you very, very much. See you soon.
It was a pleasure. It was a pleasure to be here. Thanks.
It was a pleasure. Thank you so much.
And thank you for the virtual crowd as well. It was wonderful to have, like, in a webinar, we had more than 100 participants actually logged in the webinar, which I think is a true achievement after 2 years of digital fatigue and COVID. So you certainly did a good job with entertaining them. Okay.
Thank you.
Have a nice rest of the day, everyone.
Bye bye.
Bye.
Tschüss.
Bye.
Arrivederci. Au revoir.